I haven't done anything that's as technologically diverse as this, so I don't know exactly how it's going to work, but it should be okay. I'm going to start off by presenting a healthcare experience, and then I'm going to talk about healthcare and health policy in Canada, and then I'll talk about what the changes are and why we have to change things. And then finally, I'm going to say some of the things that we're doing at Patients Canada to try to help that change to happen. So let me start off with a healthcare experience. This is a story about the experience of a family where the grandfather was a type 2 diabetic, and he wasn't looking well, and he didn't do his own blood sugar. His wife did. Which is not unusual, and it was 16. So she got scared and went to called the family doctor, but got no response from the family doctor. And she left a note at the went and left a note at the doctor's office, but got no response from that. And so there was nothing for her to do except continue to take the blood sugar. But it went up to 23 2 days later, and then she insisted on seeing the doctor, and the doctor told her to send the patient to the emergency room. So they called an ambulance. And he went to the emergency room. He in the emergency room, because it wasn't a trauma and it wasn't a heart attack, they left him on a gurney for almost 24 hours. Well, it says for 14 hours before he was admitted. That's not unusual. The patients who come in by ambulance are about 1/3 of the patients who go into emergency rooms. He was in hospital for 4 weeks. They stabilized him, they fed him, they took care of him. But he didn't like the hospital gown, so he rarely came out of bed. And his wife would bring him no food because she was Anglo-Saxon and she followed the rules. The rules were you should bring no food into hospital, so he was relying entirely on hospital food and lost something like 25 pounds. She visits him every morning and every afternoon and every evening and had to pay for parking, but there were no in-out privileges for parking, so she paid 3 times a day. His wife wanted to send him home by ambulance, but when you go to a hospital in Ontario, the ambulance will pay for the way there, but it won't pay for the way home. So they sort of shoved him into a taxi and got him home by taxi, and managed to get him up the stairs and into his bed. And he rarely left his bed except once in a while to go to hospital for the next 18 months. And in those 18 months, he deteriorated tremendously. They spent a lot of time and money on home care nurses. Finally, they decided that he would go into a nursing home. But because he wasn't mobile, they had to order a wheelchair for him. They brought him there, and 7 days later, he died. They wanted to donate the wheelchair to the nursing home, but the nursing home wouldn't take a used wheelchair because they couldn't by law. That's the story. It's not an unusual story. It's a story that happens over and over again in Ontario. So let's look at where we are and how that's happened in Ontario. Before 1850, the average longevity of people, that is your life expectancy at birth, was between 35 and 40 years. And the causes of death were most of it was infant mortality, but infant mortality through infectious diseases largely, and adults also died of infectious diseases. There were occasional epidemics when the rich would leave the city to live in the country and the poor would die off in these very large epidemics. And doctors would leave with the rich. So the poor people were left in the city to fend for the epidemics largely on their own. People died of cholera, tuberculosis, smallpox, typhoid fever, and so on. Those were killers. Those were the big killers at the time. Between 1850 and 1880, there was a major transformation in healthcare, in medicine. There was the beginning of the use of ether as an anesthetic, which allowed people to do surgery without people being in pain. And in 1867, they made the surgery actually possible, because when you had a surgery in 1850, you wouldn't have any pain, but you would die of infection. In 1867, when they started having clean operating rooms, the possibility of modern surgery began. So that was really the beginning, about 150 years ago. In 1880 and 1881, Robert Koch and Louis Pasteur proved the germ theory. That is, they could identify the germs that cause diseases, and the picture was that all diseases were caused by germs, and that if you could find the germ, then you could inoculate against the disease. You could vaccinate people. And they found vaccines. And when that happened, that was really the beginning of what we call the modern scientific healthcare system. It really started in 1880. And after 1880, hospitals were built across the world. And doctors became professionalized through a whole series of processes that was based on the scientific nature of medicine. And laboratories began to be built, and university education of doctors began to occur. And the expansion of that was the discovery of insulin in the 1920s and 30s, and the introduction of penicillin in the Second World War consolidated all of that. So modern scientific medicine reached its height at the end of the Second World War. And the hope was that medicine would be able to identify and find the causes and cures of all diseases, and there was research to go with that. So 20th century medicine is pretty amazing. It does really astonishing things to people. It does wonderful things for people, but it does very, very little. It was structured to do very, very little with people. Because as modern medicine grew, the interest was in the body and not so much the person. So if we look at the history of Medicare, it follows an interesting path. In Britain, the NHS was started. People started to fight for the NHS after the Boer War. It took 50 years for it to come into being. In Canada, they start to fight for Medicare in Canada after the First World War, and it took approximately 50 years for it to come into place as well. That the first step of it was in 1947 when Saskatchewan had hospital coverage, and that hospital coverage in Saskatchewan was a year before the NHS was founded. So Canada was, in a way, a pioneer for getting the legislation passed. And then in 1962 was when Saskatchewan introduced coverage for doctors. And in Canada as a whole, it happened a bit later. It happened in 1957, there was a national hospital insurance, and 1966 Medicare was passed, and it was adopted by all provinces by 1968-69. And then in 1984, the Canada Health Act was passed, and it declared that healthcare would be covered for medically necessary conditions, covering hospital costs and doctors' fees. And the hope was, at the time, by the people who framed the Canada Health Act, that gradually there would be more coverage for things like drugs and community care and so on. But that never really seemed to happen. So that's the kind of broad background and the broad circumstance in which we operate in Canada. But the big thing that's happened since then is that there's a huge amount of change from when we started, when this story starts. So if in 1850, 90% of people died of infectious diseases, today 89% of people in Canada die of chronic diseases. This comes from a WHO atlas that was published several years ago when they were beginning to talk about non-communicable diseases, which is code for chronic diseases, and the change in mortality was marked. And it's marked. It marks the distinction between the developed world and the undeveloped world. That in the developed world, there is this extraordinarily high percentage of death due to chronic diseases, and in the undeveloped world, there still remains quite a large amount of death due to infectious diseases. For example, the Ebola outbreak in Africa today is an outbreak of infectious disease. In Canada, less than 3% of people die of infectious diseases, including Ebola. And AIDS, including HIV/AIDS. Less than 3% of deaths are due to that. 57% of Canadians have at least one chronic condition, according to the Health Council. 36% of the population take one or two drugs a day. And Canada has the second highest per capita expenditure on prescription drugs in the world. We spend over $900 per capita, and we're second only to the United States. So these are all facts that are interesting questions, and questions that really should be looked at to try to understand what the situation is with older people. And it's worthwhile looking at a comparison between acute disease and chronic diseases. Acute conditions are simple, or they're complicated. They have clear diagnoses. Like when you go into hospital with a heart attack, there's a test that will show whether or not you've had a heart attack. And there are clear protocols for dealing with these diseases. Many of the acute diseases, especially infectious diseases, can be conquered with vaccines, and in fact we've almost conquered many of them. Everything from polio to smallpox in our countries and throughout much of the world. And almost all respond to well-established procedures or best practices or protocols that you deal with when it presents as an acute condition and you come into the hospital. There are protocols for dealing with these things, and the protocols are pretty good. They work well. And for acute diseases, we want to be in hospitals and we want to be cared for by the people who know how to care for those acute conditions. Chronic conditions are different. They're complex. They have many causes and many possible treatments. And the thing that's most important about them is that they need patient and family participation. That a lot of care can happen in the community with the participation of patients and families, and partnering with them and understanding how to work with these conditions is really not in the tradition of modern scientific medicine. And that's a really big problem that we have. I have a bunch of comparisons between acute disease and chronic conditions that I'll put up on the board. So in acute diseases, they're complicated. They're bodies to be treated that you deal with the individual body. It's not linked to other people. You don't have to face the person even very often. So knowing whether or not somebody had a heart attack has nothing to do with someone telling you what they had. It has everything to do with seeing whether or not they've had a heart attack using tests and drugs. The focus in acute diseases is on the disease and on the organ repair. You really want to be able to do that, and you want to be able to do that well. And it's important that you can do that. So there are prescribed treatments, and the person that is there is the person who has the name on the Medicare card. With chronic conditions, the diseases don't advance in any kind of regular way. They go forward, they go backward. That usually, when you're talking about someone with a chronic disease, it has to be connected not just to the person, but the people around that person, because people around that person understand that person's behavior and what their preferences are and what kinds of things they can do that will help them with the disease and so on. And usually, even in cases as simple as blood pressure, if people have high blood pressure, there isn't a standard drug for blood pressure that will help everybody. The drugs have to be tried and tested and see whether or not they work. And some of them work and some of them don't work, and some of them work over a period of time and stop working, and you have to keep on monitoring even the medications for things like chronic disease like blood pressure. Same for diabetes. The amount of drugs that people take varies and changes over time depending upon their condition and how they deal with them. And a lot of the information about that comes from the person themselves and also, to a certain extent, from their caregiver. So the difference between them is really important to note, and to note that by and large, the history of medicine and medical practice has primarily tried to deal and dealt extraordinarily well with acute disease, and has not so far dealt extraordinarily well with chronic. And this is a frame that Atul Gawande of the New Yorker really likes. He thinks that this helps explain a lot of what this is. So it's making a distinction between three different kinds of projects. A simple project, like baking a cake, where you have a step-by-step recipe and you do it once and the cake comes out, and then you do it again and you're more confident and you know that the cake will come out better, and you follow the same recipe and do it over and over and over again. And after a while, you're a master of making cakes. But you do the same thing over and again. And you don't need particular expertise. You need to have the practice of doing it over again in order to be confident of it. And the same thing goes for complicated cases. In complicated cases, it's a multiple of simple cases with a lot of technical expertise thrown in. But the formulae are absolutely critical, and following the formulae is what makes these things work. So if you build one bridge, it'll help you build the second bridge, and you'll have more confidence in it. It requires expertise of not just the engineers, but of many people working together. But it is a series of formulae, and you follow them, and they come out, and you have a pretty good certainty of the outcome if you do it well. And if you've done many, then you're more expert, and so on. It's a very similar problem. Complex problems are like raising a second child. That your experience of raising the first child is really important, but raising a second child is an entirely different project. Because what the child is like is going to have a huge influence, and you can't use the same rules. You have to adapt your recipes, as it were, to the person. Because if you try to use the same rules, you get into big trouble raising children. The thing that's interesting about raising a child is that, and about all of these projects, is that we enter them with a great deal of optimism. It's not as if we can't do this. It's that we've been trained to try to do things in a formulaic way, when in fact there are some things that we do well that isn't formulaic, that requires following the individual case and responding to it as it goes along. And we're quite good at that too. So people aren't bad at raising their second child, and aren't pessimistic about it, and think that if they don't have the recipes they can't do it. It's that we're not used to doing things in that way. We think that everything should be done in the first way. What's interesting about people with chronic conditions is that people with chronic conditions are healthy. They're not sick. So someone with high blood pressure can be as healthy as somebody without high blood pressure, can engage in the same activities, can do all the things, but has to be careful about the high blood pressure. And they feel perfectly healthy. It's not as if people with high blood pressure feel ill all the time. Some of them do, but most of them don't. The same thing goes for people with diabetes. Right? The same thing goes with people with many chronic conditions. One of the most important tests that's done, and one of the most important reviews that's done, is to have people self-assess their health status. And the self-assessment of health status is an excellent indicator of future health. It's been validated scientifically. What's interesting is that 75% of people with one chronic condition feel healthy, declare themselves to be healthy, and respond that they are healthy when asked on these questions. And 50% of people with two chronic conditions feel the same way. And the question in our system then is, how do we keep them feeling healthy? How do we do that? And it's a question that we don't answer, by and large. We don't put very many resources behind answering that question. Secondly, it's really important that specialist care outside the hospital is there to avert acute episodes. It's not there to deal with episodes once they become acute. That the idea is that you get medication and advice about lifestyle, and you're supposed to help you stay out of hospital. So a hospital that's friendly for older people will provide medical care that maintains and improves health. And given the condition that there are very large numbers of people with chronic conditions, the question in our society is, how do we go about doing that? How do we go about maintaining and improving the health of people with chronic conditions? And it's a question that our system, that we all ask. It's not that we aren't aware of it. It's a question that our system responds to very badly. We don't have the resources for this. We don't place the resources there. The resources tend to fall into another area. So the challenge for providers is that The system has been in the past risk-averse, huge information control, a great deal of professional authority, very high boundaries both between patients and providers, but also between specialists, also between different providers. So in the coming changes, because people will be moving around the system, we have to be much less risk-averse. We have to be ready to try things. We have to have much more information that passes across all of those boundaries, and we recognize that, and we recognize the difficulty of passing information. We talk about it. So that change is a change that's in the process of happening. We're trying to have happening. When they talk about open information, it's now talked about in terms of interoperability. But really, part of the difficulties of interoperability is that the history of the lack of interoperability is not just a lack of technology, it's a lack of will to exchange data. So let's see how we've coped in Ontario. In 2013, healthcare expenditure in Ontario was $48.9 billion. 58% of the budget, it turns out, according to ICE's data, goes to 5% of the patients. Almost all of these patients are patients with chronic conditions that have repeat hospital visits. We know nothing, almost nothing about that 5%. We have no research that's looked at it. We have the numbers, but we don't know exactly who they are because we haven't done research to find out who that 5% is that spends all the money. My guess is that a lot of these people are people with chronic conditions who have repeat visits to hospitals when their conditions become acute. If we assume that everyone in Ontario uses the system at least once, it turns out that 675,000 people in Ontario consume $28.4 billion, which is a huge amount per capita. It's a huge amount for each person. It's far more in expenditure in hospital than it would cost to put a lot of resources in the community to avert these hospital episodes. I mean, that's the big point of all of this. It's clear that more services that meet needs of these people in the community could avert that cost. There have been other reports like this. In Quebec, there is a report by Robert Salwa that just came out a few weeks ago. And he has the data for emergency room visits in 2013 in Quebec. There were 3.4 million emergency room visits. A third of them were by ambulance. And the average length that an ambulance patient waited in the ER for treatment was 18.4 hours. So if you come into an emergency room after a trauma, you're seen immediately. That's about 1% of ambulance cases. If you come in and you have a heart attack, you're seen immediately. If you come in and you have an infection and you have to be given an antibiotic IV, you can wait as much as 18 hours to get it. The average across Canada is lower than 18 hours. It's about 14 hours. And the ratio of 1/3 to 2/3 visits to emergency rooms is the same. So when you go to the emergency room as an ambulatory patient, it's usually 4 to 5 hours. If you go to the emergency room and you're a trolley patient from an ambulance, then it's between 14 and 18 hours. And if you think about old people, and most of these people who come in on a trolley and wait for such a long time are older people. So hospitals structurally are not friendly to older people if they sit on trolleys for 18 hours. It's not a question of changing that, because there's not much you're going to do about it. Okay? So what happens is that if you sit on a trolley for 18 hours, you sit on a gurney for 18 hours, then the 5 problems that older people have when they come to hospital emerge exactly by being in that position. The lights are on for the whole time, so you become confused and you don't get any sleep. You're not taken off the trolley to walk around very often because you can't walk, but you're also not given any chance for mobility or for walking at all. There's no walkers, there's no one's going to take you for an exercise walk. So your mobility is poor, deteriorates, and you have poor balance after 18 hours on the gurney. It's like you also don't get any food service, or get very little food service, so you're not given proper meals in that period of time. And finally, you get bed sores because nobody is going to turn you. So if you have skin that's damaged, the chance of starting to get a bed sore after 18 hours in the gurney are high. So all of these things are consequences of this structure. Right? And changing the structure is not just a matter of providing better care for patients in hospitals, it's finding ways to avert the hospitalization, because much of it can be averted. 2 weeks ago, Simon Stevens, who's the head of the NHS in England, published a 5-year plan, which is called Looking 5 Years to the Future, which is accessible on the internet. So if you go to the NHS and look for 5-year plans, Simon Stevens' 5-year plan, you'll get it. And you can download it for the policy wonks. It's all readable, and it's a very good thing with a very good executive summary. So it's a good thing for you to have. And it has 5 key points that he's going to do in the NHS. He's going to increase prevention and public health as part. He's going to link them to healthcare better, and he's going to fund them through the healthcare budget. In Canada, public health wasn't funded through healthcare, and one of the things that's just happened is that the public health system is just now being part of Health Canada again, and it'll become part of Health Canada, and we'll see whether or not that makes a difference. What they did was they took healthcare away from doctors and gave it to bureaucrats, public health rather. There'll be increased, patients and family caregivers will be given far greater control over their own care, including getting money for it. So a lot of the problem, the biggest capacity for taking care of people with chronic conditions is that there are family caregivers who constitute a huge amount of help for family caregivers and are unpaid. And so the question about the kind of funding that they need and the kind of support they need in order to provide that kind of care is going to be increased in England. Thirdly, there'll be more NHS support for the voluntary sector connected to health. All the friendly visiting and Meals on Wheels and volunteer transport groups will be getting funding for this, and other voluntary organizations that help people stay in the community. He also wants to break down barriers between family doctors and hospitals and between all the different parts of health so that there's better transition. And finally, the idea of delivering more care and a broader range of care locally, and the idea is to have specialist clinics in various communities where specialists will be able to provide for the care of people with multiple chronic conditions in the same place at the same time. So those are the kinds of things that they're thinking about doing in England. We don't know how many of them they'll actually do, but that's the kind of picture that responds to a certain extent to the situation that I've described. So what are we doing at Patients Canada? Patients Canada is an organization that's made up of patients and family members, and doctors and nurses and policymakers. The idea of the organization is to help patients participate, become partners in their health care, but also become partners in the development of new services and the design of policies and the doing of research. And the way we work is that we get patients to send us their experiences with healthcare, like the first experience that I described at the beginning of this talk. They tell us, they send their experiences to our website. We have a program with the Ontario Medical Association where patients nominate doctors who are especially patient-friendly, and then a patient jury selects the winners, and then the doctors who are special are given an award at a ceremony by the President of Patients Canada and the President of the OMA. So the idea is to recognize people's good experiences as well as their bad experiences and learn from them. We also actively search for experiences across the internet and from many sources. In fact, most of the time that we talk to people and we explain what we're doing, people will will tell us an experience, will provide us with an experience that they've had with healthcare, either good or bad, and we listen to them. We begin all our board meetings with a discussion of patient experience. But we have a panel that meets on a regular basis and goes through experiences and tries to see what are the things that have to change in order to make that experience even better if it's a good experience, and what will make the experience, make people's experience improve in general in healthcare. And we develop key performance targets to do this. And the idea is that the key performance targets are not based on how people feel. They're based on things that can be done that are easily measurable, that are concrete. And we try to find ones that are rather simple to implement and that can come into effect relatively quickly. So we bring these experiences to our panel. There are discussions at the panel, and we sort of distill them into particular experiences, and then they're reviewed by a panel of doctors and a panel of policymakers and a panel of managers to make sure that they can fit. And I'll give you some examples of them. So this is the idea that we have people's experiences, we collect them, we discuss them, we develop the targets, and then we start to design the changes that will happen in a particular place. This is the pathway that goes from the experience to the impact, where we start to make changes and see what the impact is. And we've developed these KPTs, and they are making a difference. So we sit on Health Quality Ontario Primary Care Measurement Group on their steering committee, and we contribute the indicators that we have to them, and they've taken up some of them, not all of them, and so the measure of primary care performance will be influenced by the work that we've done. Similarly, we sit on Accreditation Canada's patient committee, looking to make accreditation more patient-centered. And we've just completed the change in the accreditation process, and that will be sent out to all healthcare organizations in 2015, and it will become part of accreditation in 2016. So it's a major change in accreditation to look at areas in which very concrete areas in which the organizations are more family and patient-centered. We work with CIHI, and we're participants in a large project in Coburg to look at transitions and to help people deal with transitions. And we meet with hospitals and LHINs to look at some of these. And we're a member of a very large grant, the Ontario SPORE grant, that will fund us for the next 5 years to develop these key performance targets. But you don't know what they are. So let's look at the story. Here's the type 2 diabetic that I told you about. If I ask you to think about things that could change in there that would make their experience better, what would you include? Do any of you have any ideas? Yes. Microphone. Yeah.
I think your idea of developing a community care system is the key here. And I stress the word system, just investing more money in a few community care services that don't cooperate.
I agree.
That's not really what you need. We need a system that will see the person immediately go to the home if necessary, be able to escalate things, bring them to an urgent care clinic. But that investment in a coordinated system has not really occurred.
Yeah, the truth of the matter is we don't have such a system at all. We have home care, which is not a community care system, and the idea of what constitutes community care is exactly right, that broad picture of community care is what we don't have and which has to be developed. I agree with that, yeah. But you can think of particular things here. That's a very broad thing. Some particular things here that would make a difference. That one of the things that could be ensured in this case is that there is same-day response to questions in primary care. Yes?
I'm just going to make a comment from the emergency emergency department perspective, which is where I practice, and we have a program in place in Ontario in our emergency departments to help identify high-risk seniors and provide their geriatric assessment in ED. And I think they are a missing link. And that in your example, I think an assessment by an emergency nurse with geriatric training could be a key thing to help change the outcome.
Yeah, I think that that's right. I think that that would be a key thing to change the outcome. What would be better would be to have community services that could avert the movement to the emergency room. So getting geriatric nurses out into the community to help patients before they get into the ambulance would be a much better way of doing it.
Yeah, I agree with that.
Yeah, I think we all do. I don't think that this is rocket science. Yeah.
But we also know that in a crisis, many older people
That's right.
that are frail and have chronic conditions do appropriately use the emergency department.
Oh, absolutely. I think that the use of the emergency department is largely appropriate. I think it's systematically inappropriate. It's not inappropriate by the individuals. Given current conditions and given current services, yes. And the thing is that we don't have services that allow other possibilities to occur. I think you're absolutely right. I don't think that people misuse the emergency room. I think that that's a big mistake. I mean, that's blaming the patient. It's not the patient's fault at all. It's that's where you have to go now. And I think the other thing I think, and I should say it, is that I think that hospitals are behaving extraordinarily well in responding to that influx of patients by having programs like yours. So this is not a complaint about that hospitals are treating people badly. I think it's that the circumstance is such that it's one that we want to avoid. Yeah, and I think you agree with that, right?
Absolutely. I'm
Yeah,
saying in your example, I think that...
Yeah, that's right. And I think that, yeah, so the really important thing is we're not blaming anybody. We don't think that it's people's fault. And the idea that one of the things that people think, oh, well, people are saying that the emergency room is a bad place. Yes, it's in some ways it's a bad place, but it's not, there's no alternative now. And I think that people try as hard as they can given these adverse circumstances. I think that that's right. And that's really important. So the idea we're out to get them is a mistake. Yeah. The thing that there are some other things here that very often specialist services are in the hospital and there are multiple specialists and there's no way to see a number of specialists on the same day. So people who are going for multiple chronic conditions go on different times to different specialists to get care. So there should be ways of bringing that together. The other thing in Ontario that's particularly interesting is that transport to hospital is paid for. So you get an ambulance and you go there, but no transport from the hospital isn't paid for. So old people who are frail and who have to be moved from the hospital have to find their own way home. We need, obviously, I think that the big line is the thing that the gentleman in the back said, is that we need a community care system. And we need, it's much more than comprehensive home care. And we need much more support for family caregivers, who are the people who take the largest burden of these things. And finally, in this story, it's quite clear that we need wheelchair libraries so that there aren't any used wheelchairs, wheelchairs can be reused. But we have developed, and for this talk, we can declare 6 KPTs for to make hospitals friendly to older people. The first one is about hospital gowns. That hospital gowns should not be obligatory in hospitals because they take away people's dignity. And what's interesting is that about 80% of people who are in hospital don't have to wear them. So we can get rid of a large proportion of them and redesign the ones that are left so that they aren't so as undignified as they are. Now people wear 2 hospital gowns. Right, one in the back and one in the front. There are a lot of that going on. So the hospital gown clearly isn't properly designed, and people are redesigning it, and it's time for a change. The second thing is parking fees. The Ottawa Hospital is a good example of a hospital that has relatively high parking fees and relies on those fees. But these parking fees can be really punitive for people. If you have a relative with a heart attack and you come into the Ottawa Hospital in the morning, what's the daily rate here? Do you know? 13? So you pay $13 in the morning because there are no in and out privileges. If you come back in the afternoon and stay for 3 hours, you pay $13 in the afternoon. And if you go out and come back in the evening, then you'll pay $13 in the evening. So if your husband has a heart attack and you're there for 5 days, then you figure it out.
There are weekly parking passes.
Yes, but the weekly parking pass office is in the back of the hospital and has to be found and you have to be told about it. Yes, there are. So there are policies in place, but the practice is that when you come in, you pay the full whack and you pay it over and over again. And I think you're quite right that people are cognizant of it, but the way in which their policies are put in place are ones that many people don't take advantage of it and in fact are harmed by it. So thinking about parking and making it better and easier for people is really an important issue. For patients. The third thing is that in the triage position in the emergency room, there are always 2 chairs. There's a chair for the triage nurse and a chair for the patient. It's interesting that over the years, nobody has thought of putting in a chair for the family member who accompanies the patient. And so we suggest that there be a 3rd chair in the triage position. And some hospitals are beginning to take it up. Yeah, did you? No. A 4th thing is that there be a visiting policy that's open that allows people to come. Usually the visiting policy is there and it's not followed. But it would be very nice to have a visiting policy that's open. Because if it's not followed, it means it's not followed by some people, but it's followed by others. So there are some people who leave and shouldn't, and some people who are there and shouldn't be there. And so how the visiting policy is done, making it more patient-friendly and more open, and figuring out what to do with it, is a big issue for patients and families. The 5th thing is that there should be a care plan for older people that's devised early on. And I think that the nurse in the emergency room pointed out that the geriatric nurses come early. And starting to develop a care plan at that point, understanding how the patient will be cared for, is quite a critical step. And making that care plan together with family members and with patients is a big deal. And making it open to them so that people know how their relative will be cared for and making sure that that happens becomes a very good thing to do. Yes?
I think the idea of a care plan is a nice idea, but it's not always practical. In acute care, parts of it are practical. We're going to walk along, we're going to go through the investigations, but there's a big part of the plan that changes day by day. As the condition changes, as the diagnosis becomes more apparent. So I guess you can do part of the care plan, but the situation when in reality in acute care is every day is a different.
Yes, and I think that every day and every different day that whatever is in that care plan and in the changing care plan should be open and accessible to patients and families. That's all. Yeah. So it's not a matter of having a rigid care plan, it's of having an adjustable one that everybody is aware of.
Once again, I agree with the principle. It sounds good, but in acute care, we're run off our feet. We have E15. We're spending so much time documenting, writing things down.
Yeah.
The actual care of the patients is deteriorating and mistakes are being made. So there's a sort of a knowledge overload and a task overload that's going on. So all of these things have to be done in a way that saves time.
Absolutely. It should be done in that way, and it should be electronic, and it should be accessible to patients and families. Yeah, so I'm not denying all of that. I accept that and sort of say, making it more accessible to patients and families. The other thing that's come up is that people are now working on a patient-accessible and a patient-developed discharge summary. That discharge summaries tend not to be patient-friendly and tend not to be useful. And redesigning the discharge summary to make it more patient-friendly would be a very good step in this, especially in this kind of case. And the last one is hospital food policy. That hospital food policy should be known to family members. It turns out that our patient in our story didn't get food from his wife because she thought that they couldn't bring food into the hospital. And so he lost all this weight. But if she were told that it was possible to do that and that there were facilities to help do that, that would really help. And that's something that interesting from the patient's point of view, isn't in place yet. It's easy to do. So these are 6 things that are concrete and that we could measure, and that to a certain extent what we would do is negotiate how they're done. And we partner with hospitals on them. So we've met with CEOs and VPs of patient experience, and we partner with hospitals to elucidate and implement these key performance targets in their hospital, because there'll be adjustments in each hospital that have to be made. And if they get many of them done and work on them, then will be certified as Patients Canada partners in patient-centered care and can be sponsors of the developments and implementation of the next set of KPTs. Because these KPTs come from patient experience directly and will help improve patient experience. We have a SPORE grant, a big SPORE grant, to proceed with the evaluation of the impact of these changes on patient experience, and we'll evaluate and report that back to everybody. So that's pretty much my talk. And now we have time. Terrific. The timing is perfect. We have time for questions.